My name is Daniel. Today I'm going to be doing a presentation on rabies. So the main resource I used was the South African guidelines for management of rabies. Let me just try and go to next. There we go. So it's in 2021. Okay, so what is rabies? So rabies is an important but neglected zoonosis that can affect all mammals, including humans. So it's caused by various species of the lassa-virus genus. All species of this genus can cause rabies disease, but the majority of human rabies is caused by rabies lassa-virus, so the rabies species of lassa-virus genus. So it spreads from peripheral nerves to the central nervous system, causing a fatal encephalitis, but it is 100% preventable with post-exposure prophylaxis. Okay, so this is just a cartoon. Okay, so here are some of the main species which transmit rabies to humans in South Africa. As you can see, so there's domestic dogs and cats, as well as some like wildlife species and even livestock as well. So this is just a breakdown on some of the confirmed rabies cases in animal species in South Africa. And as you can see, the vast majority is due to the domestic, found in domestic dog. But you also get black-headed fox, black-backed jackal, and other species as well, which can acquire rabies. Here's just a breakdown of where these rabies has been identified in different species of animal. And as you can see, in like domestic and the canine species, a lot of the cases are in Eastern Cape, KZN, Mpumalanga, Free State, and Limpopo. And there's also other wildlife cases that have been identified in the rest of the country. So the clinical presentation in animals, there's no definitive clinical signs of rabies. Mostly you will see behavioral changes in the animal and neurological signs are dominant. There's often this prodromal phase, which is symptoms or signs, followed by a furious or dumb form of rabies. Here's just some of the different presentations in different species of animal. So domestic animals may become like more aggressive. They may attack without provocation, and wildlife species can appear tame and might approach humans without any fear. But there's a lot of other different presentations. They might be having an asexual gait. They might be drooling. There's a lot of different symptoms which they might present with. Okay, then so rabies is also found in bats. So there have been rare cases of rabies virus transmission from bats which have been infected with the Duvenhague Lassa virus. And since bats can be very small, weighing as little as 10 grams, their bite wounds aren't always visible. So due to the fatal nature of rabies, in the absence of administration of PEP, PEP should be administered even if there isn't a clear history of exposure and if direct contact with the bat cannot be excluded. Okay, so diagnosis in animals. So first of all, laboratory diagnosis should never delay management. So administration of PEP should always be given, even if there isn't a clear history of exposure. But the diagnosis in animals relies on basically any animals showing neurological signs or otherwise wild animals which are suspected in exposing humans to rabies. Their brain should be submitted for laboratory examination, and the test they use is the fluorescent antibody test to detect the rabies antibody in the postmortem brain of these animals. Okay, so which animals generally transmit rabies to humans? So the vast majority of transmission is from domestic dogs, and there are a few cases from domestic cats. Okay, so transmission is through the virus-laden saliva of the rabid animal, through bites or scratches which penetrate the skin. Contact with saliva on mucous membranes is also considered a possible exposure, but contact of saliva with intact skin is not considered an exposure. There's also been a handful of cases of transmission through transplants of organs such as cornea from patients who have died from undiagnosed rabies. There's been no documented cases of human rabies through transmission from consumption of raw meat or milk from rabid animals. And in very rare cases, there have been documented cases of rabies transmission to humans through inhalation of aerosols in laboratories where they're working with rabies virus, or otherwise in caves where there's a lot of rabies-infected bats. Okay, here's another cartoon. Okay, so the epidemiology. So how many cases of rabies would you think on average are confirmed in South Africa each year? Okay, so on average, about 10 cases of human rabies are confirmed annually in South Africa. And this is obviously dependent on testing and reporting of the rabies infection. So rabies disease might be much more prevalent than this, but it really depends on us testing appropriately. Okay, here's like a breakdown of human confirmed rabies infections in different provinces of South Africa. And as you can see, a lot of human rabies is found in KZN, Eastern Cape, Limpopo, Mpumalanga, and Free State. But there are rabies cases that have been confirmed in other provinces of the country. Okay. So the clinical presentation in humans. So as soon as symptoms and signs are obvious in humans, the virus is almost 100% fatal. But during the incubation period, there's often little or no clinical signs. A few patients may complain of like numbness or pins and needles at the bite site, but often there's no symptoms. There's also no diagnostic tests available to confirm infection. Around about 2/3 of human patients will develop what they call furious rabies. So they can be hyperexcitability, generalized arousal, hydrophobia, aerophobia, aggression, confusion, and other symptoms. And then in about 1/3 of cases, they might develop what they call dumb rabies, or the paralytic form, which is similar to Guillain-Barré syndrome. And most patients die within a week of symptom onset. Okay, so what would you think that the incubation period of rabies would be? So there's quite a wide range. So it's typically between 20 and 90 days, but in certain patients it might be shorter than this or a lot longer, especially in patients with bites to the face and where it's close to the brain. Symptom onset might be a lot sooner than 20 days. The diagnosis is basically, the clinical diagnosis is based on a progressive encephalitis where there isn't an alternate diagnosis. And there may also be a history of a possible exposure to a rabid animal, but this often isn't forthcoming. Okay, so in your differential diagnosis, you would consider other causes of delirium, such as bacterial or viral meningitis, encephalitis, such as cerebral malaria, acute flaccid paralysis, especially in maybe the dumb form of rabies, and also non-infectious causes such as snake bites or psychosis, and electrolyte abnormalities, and other causes of delirium. So laboratory diagnosis is based on detection of viral RNA in saliva, CSF, or nuchal biopsies. And the gold standard is actually the detection of rabies virus by this direct fluorescent antibody test on postmortem brain. So going into a bit of the antemortem diagnosis. So for saliva specimens, that they recommend at least 0.5 milliliter of saliva in a specimen container collected on 3 consecutive days. In CSF, again, about 0.5 ml in sterile plastic tube. And then on nuchal biopsies, they can either be a punch biopsy or can be an excision biopsy. And they recommend around about 0.5 centimeter depth and 0.5 centimeter diameter, taken from the back of the neck, and should contain these hair follicles because they're associated with cutaneous nerves deeper in the skin, and this is where they locate the rabies virus. And you can submit that on either with on a gauze with either saline or just tap water, and you don't need to add any fixative to the specimen. Okay, so I'll just briefly talk about PrEP because we don't have really much exposure to this. So the pre-exposure prophylaxis, this is for individuals at high or continual risk of exposure, such as vets or animal healthcare workers, bat enthusiasts. Also, you might consider it in people planning to travel to endemic areas where they may not have access to post-exposure prophylaxis if they do have an exposure to possibly a rabid animal. Okay, so the PrEP regimen that they give us in South Africa. So we've got the Vera-Rab vaccine, and for PrEP they suggest 2 doses, one on day 0, the day of presentation, and then one on day 7 days after presentation, and it's 0.5 ml injection IMI into the deltoid muscle. So that's 1 amp of the Vera-Rab vaccine. And then, so moving on to post-exposure treatment. So first of all, we should never forget like the emergency management. So with basic trauma principles. So you would start off with a circulation. You want to look for signs of shock. You want to control any active bleeding. Patient might require IV line fluid resuscitation and blood products. And then you would want to assess the airway, check that they're able to maintain airway. Maybe it's a child that's been bitten to the head. They might have a decreased level of consciousness. You might want to consider whether intubation is needed. Onto breathing, you would look for signs of respiratory distress. Maybe they've got bites to the thorax. Maybe they've got a pneumo or flailed chest. And then for disability, GCS, and you would also want to prevent hypothermia and then get a history from them. And also on secondary survey, you would want to examine head to toe, log roll them, make sure there's no other wounds that need hemostasis. And then you might consider adjuncts like blood gas or x-rays to look for underlying fractures. So for general wound management, once you've stabilized the patient, you'd also, especially in children, you would consider a procedural sedation and analgesia, because you'd want them to be comfortable and cooperative so you can clean out these wounds thoroughly without causing them stress and discomfort. So you'd want to flush and wash wounds for at least 5 to 10 minutes using soap and running water. You might also want to use like flushing with high pressure, so maybe a smaller syringe into the puncture wounds to make sure that you're disinfecting deep within the wound. You can also apply disinfectants such as chlorhexidine, but you'd want to avoid iodine for deep lacerations, as this might lead to devitalization of the tissues. Also for extensive wounds, you'd be considering, and if they're also dirty and contaminated, you'd be considering debridement, even possibly surgical debridement. in which case you'd be consulting the general surgeon or the pediatric surgeon, and you'd be looking for associated fractures, ligament, tendon injuries, nerve and vascular injuries, and also in the case of extensive wounds, you'd want to be monitoring them for crush injury. Okay, then you'd be wanting to give them a tetanus toxoid if they haven't been immunized within 5 years, covering with broad spectrum antibiotics with gram positive and negative cover, such as augmentin, for all category 3 and hand wounds, and then also probably wounds to the feet as well. And they suggest that suturing of wounds should be avoided unless it's needed for urgent hemostasis. And also local anesthetic agents should be avoided as well, since suturing of wounds and also the injection of local anesthetic agents may spread the virus locally. Okay, so a bit more on post-exposure prophylaxis. So it's the only intervention for human rabies. Once a patient's symptomatic, there's no other treatment that we can give. So it's considered emergency life-saving medical treatment, and the decision on whether to give PEP is, they say, is based on health status of the animal, its behavior in that particular incident. So was it an unprovoked attack? Was the animal unusually aggressive? Or were they showing neurological signs, or were they otherwise showing signs of illness? The animal species was, as we can see, like the different animal species have different rates of rabies disease, and also the vaccination status of the animal, local and provincial rates of rabies. Often we don't really know the vaccination status of the animal, and often we rely more on the bite wound category, and we tend to err on the side of caution in wounds that would justify post-exposure prophylaxis. So going a bit more into the categorization of wounds, so it's divided into category 1, 2, and 3. In category 1, there's maybe being in the presence of a rabid animal or petting an animal, but there's no breaching of the skin. Maybe it's an animal licking intact skin, in which case they just suggest washing of exposed skin surfaces. Then in category 2, there's direct contact, but there's no breach of skin and there's no bleeding. So maybe bruising or a superficial scratch, which doesn't show any bleeding, in which case they suggest usual wound management as well as a full course of rabies vaccine. In category 3, this includes any wound with any breach of skin, any amount of bleeding, or otherwise contact with mucosal membranes, such as like a lick from maybe a feral animal on the eyes, nose, or mouth, and any contact with broken skin. So maybe, if a feral animal licks a scratch wound on the skin, and any contact with bats is considered a category 3. In category 3, they recommend immunoglobulin as well as the usual wound management and the full course of rabies vaccine. Okay, so obviously in this picture, this is looks like quite a friendly dog. It might even belong to this child, but based on the categorization above, what form of exposure would this be? Say, for example, this is actually a stray dog and we've got no idea of its vaccination status. This would be considered a category 3 because it's licking on mucous membranes. And so what category would you think this would be? So it's a category 2 because there's no bleeding, there's no breach of the skin, but there is bruising at the wound site. And which categories would be put these under? So all of these would be category 3 because there is breach of the skin, and you can see in the pictures also There's some bleeding as well. So all of these wounds would require immunoglobulin as well as wound management and rabies vaccine. And this category, so if these are feral dogs, we don't know their immunization status. So this would be a category 1, which is no direct contact with mucosal membranes. There might not be any abrasions or lacerations or anything like that. Okay, so basically a summary of the rabies vaccination schedule that they recommend. So in South Africa, we've got the ViroRab, not the Rabipur injections. And the ViroRab is a 0.5 ml vial, and you use the entire vial. It's an IMI injection into the deltoid muscle. In children under 2, you can inject them into the anterolateral thigh. And you're giving 4 doses. Day 0 is the day of presentation, then 3 days after that, then 7 days after day 0, and then anywhere between 14 and 28 days after presentation. Okay, so what is the dose then for children? So the doses for adults and children is the same. It's 1 vial per dose. That's 0.5 milliliters. And then what do you do if a vaccine dose administration is delayed? Okay, so instead of restarting the PEP regimen at day 0, you resume it at the dosage that they missed, and then you continue from there. And can rabies vaccines be co-administered with other inactive or live vaccines? And the answer is yes, they can. Just need to use separate syringes and different injection sites. Yeah. Okay, so rabies immunoglobulin. So we get it in 2 forms. The one is human-derived, the other is equine-derived. And they suggest that with the equine-derived immunoglobulin, that it be administered in facilities where you can manage anaphylaxis, even though the incidence of anaphylaxis with the equine-derived immunoglobulin is low. Skin testing isn't required before administering it, and it acts by neutralizing the virus at the wound site. And the reason why we give this is because the vaccine takes at least 7 days for it to elicit an immune response. So while your body's mounting this immune response, the immunoglobulin neutralizes the virus at the bite site. Okay, so after 7 days of giving the rabies vaccination, immunoglobulin is no longer indicated because the body is already mounting an immune response to the virus. So there's no benefit after 7 days after vaccination. They suggest infiltrating the entire dose of immunoglobulin in and around the wound sites. In smaller wounds, they say infiltrate as much as you can without causing compartment syndrome. They no longer recommend injecting the remainder of the calculated immunoglobulin at a distant site. And for large wounds or multiple wounds, they suggest diluting with saline in order to allow maximum infiltration around all the wounds. So management of mucosal exposures, they suggest rinsing thoroughly with water, and on a case-to-case basis, considering rinsing with diluted immunoglobulin. And then in these exposures, a full rabies vaccine course should be completed. And if there is a bite site or wound or laceration, that area should be infiltrated with immunoglobulin. Okay, so the dosage for human rabies immunoglobulin, so we've got Rabigam, so that's dosage is 20 international units per kg, and it comes in a 2 ml vial of 150 international units per ml. And this is given on the day of presentation, day 0. And then for equine-derived immunoglobulin, it's double the dose. So you're giving 40 international units per kilogram. And that's besides that, you're using the equine-derived immunoglobulin in exactly the same way. Okay, so in immunocompromised patients, so the only difference here, so these include patients with symptomatic HIV, cancer patients on chemotherapy, patients on steroids, and the main difference is that you're giving the rabies immunoglobulin in category 2 wounds as well, but then you're still following the same full course of vaccine administration, and there's no need to give an extra vaccine dose, even in immunocompromised patients. And patients on antiretrovirals and ones that aren't considered to be immunocompromised. Okay, so in pregnant and lactating patients, rabies vaccine and immunoglobulin are safe and effective, and the dose is exactly the same. So for patients that have received PrEP, so then you're going to be giving just 2 doses of rabies vaccine on day 0 and day 3, and there's no need for immunoglobulin because their body should already be mounting an immune response. Okay, so if a patient's already received post-exposure prophylaxis within 3 months, then if they have a repeat exposure, there is no need to restart another post-exposure prophylaxis. But in exposures occurring over 3 months after a last PEP, then you're going to give 2 doses. So you're going to be treating almost as if they've received PrEP, again on day 0 and on day 3. Okay, so what do we do if there's a delayed presentation? So first of all, PEP should be given as soon as possible. But even if there is a delayed presentation, we treat the first day of presentation as day 0 for vaccine and also immunoglobulin administration. So even when the wounds have healed, you can infiltrate the immunoglobulin in and around the previous wound site. So in conclusion, rabies is a neglected zoonosis, which is endemic in South Africa. It's mostly transmitted through dog bites, and it is almost 100% fatal once symptoms appear, but is completely preventable through post-exposure prophylaxis. Okay. I don't know if anyone's logged on, if there's any questions.
There are lots of people logged on. I just wanted to say thank you from my side, and I'm going to give everybody a chance to make a comment or ask some questions. And what I'm also going to ask is, Dan, would you be able to sort of go out of your presentation, stop your screen share, and make me the host if possible?
Okay.
Anybody questions?
Hi, everybody. It's Leslie here. Dan, I just have a question. I had a patient not so long ago that missed their follow-up vaccines. So, for example, if they present today and they were meant to have their dose yesterday for like day 3, for example, is day 7 calculated from the original dates or new dates starting from today if they missed their vaccine?
As far as I understand, it would be calculated from the new date. So if they presented now and they missed the day 3, then you count that as day 3, and then you count from day 3 to day 7.
Day 7 and then new day 14. Okay, thank you so much, Dan.
Cool.
Hello.
Hi.
Can you hear me?
Yes, I can. How did you do?
Yes, it's the day here.
Yes.
I have a question. You mentioned the site of injection
Yes.
is in and around the world. They do not encourage injection away from the site,
Yes.
or if I heard you correctly. So,
Yes.
like if a
Yeah.
patient has just a puncture wound, let's say on the foot,
Mhm.
so obviously you won't need a huge volume. What are you doing with the rest of the vaccine then? Do you
So
put,
you
do
actually,
you inject, for example, in the thigh or?
yeah. So like interestingly, so it looks like on the new guidelines, you're basically infiltrating as much as possible in and around the wound site, because the immunoglobulin works to inactivate the rabies virus in that area. But they no longer recommend injecting it at a distant site, even if you've got a very large calculated amount that you need to inject. You inject as much as possible where there are wounds, and then there's no need to inject the remainder anywhere else, because it works to neutralize the virus at that site, whereas the vaccine works to stimulate your immune response throughout your body. So yeah, I don't know if that's clear.
Yes, yes.
Okay, great.
Okay,
Hi, Dan.
Hi,
So,
Nazir. Go ahead and ask a question.
if the bite is like in the mouth, can you, like in the gum, can you still put the immunoglobulin around it?
Yeah. So if you definitely, yeah, with the mucosal exposures, if there is any lacerations or if there's any puncture wounds, if you can access the site and if you can put a needle in, then you can inject around any wound that's basically breached the skin.
Okay, thank you. And the other question was like, if the patient presents like on day 3, post having a dog bite, do you start the vaccination process from like day 0, or do you go on to like day 3?
So it looks like because the incubation period can be so long, it can even be even like theoretically, if they presented a month after the bite, you would still consider that day 0, and you would still give the immunoglobulin, even if the wound's healed over. You're still injecting it at that old wound site, and you're counting that as day 0 for immunoglobulin. Sorry. And then also day 0 for beginning the full set of vaccinations.
I'm going to ask a question.
Sure.
What about rabies with regards to being a notifiable medical disease?
Okay, so there's actually a lot of good resources on the it's like an NICD website where you can actually download the rabies notification forms. But yes, yeah, it's definitely a notifiable disease. I didn't really go into that in my talk, but they've got really good resources on their website.
Can you guys see my screen?
Yes, yeah.
Okay,
Yes.
so this is the form that we are supposed to use for animal bites where we're suspecting that there might be rabies. So it is not for the cases where we know for sure that this patient cannot have rabies. It's a local pet, your pet is vaccinated, the neighbor's dog, they're vaccinated. So we don't need to use it for that. But this form is required for all bites where we're suspecting rabies. So essentially, if you are giving a rabies vaccination, you need to fill out this form. You also need to then complete the form and then forward it to the emails listed at the bottom. So the NICD team actually collects these forms. because suspected bites that are suspected for human rabies, we need to fill in this case history form. If you've got a patient that has got a category 3 bite, so if you are using immunoglobulin, please remember that that is a notifiable medical condition, and then you need to use the standard notifiable medical conditions case notification form, and then email this form through to the email address listed there at the bottom, to the NICD website. So that's just in addition to this really fantastic talk that Daniel has done for us. Please remember that suspected rabies, category 1 or 2 bites, or 1 or 2 wounds, as well as 3, you would fill in this form, but with 3 in addition, then you would notify. If you've had to use immunoglobulin because it was such a high risk wound, under such a high risk exposure, you would also use this notifiable medical condition form. Any questions, any comments? Okay, I'm going to say then that I'm guessing that if there's silence, nobody has got any other questions or any other comments. Thank you, Daniel, very much for presenting for us. It was a really informative talk. And thank you for putting in the effort to do this talk for us.
Thanks, Tammy, and thanks, everyone. Yeah, have a lovely afternoon.
Okay, thank you so much. Goodbye.
Bye.